واضحة كده؟ واضحة ولا زوم شوية؟ زوم شوية كده.
ذكرى الدكتور مدحت الهناوي أول من قدم الفيكو لإسكندرية، فسبقنا خطوتين ثلاثة. كان الراجل يعني عنده بعد نظر، وكان أياميها مع الفيكو قلنا فيكومانيا. الاسم فكرني بالإمبريشن اللي اداله انما هو كان بعيد نظر عن
مش عايز لا
ما كانش في حد هنا ما هوش مشتغل فيكو، فهو دي فضل علينا كلنا في الديو ليكتشر باسم الهناوي ليكتشر.
بسم الله الرحمن الرحيم. اولا شكرا للحسين على الجميل ده، انا ما استحقوش طبعا. وطبعا يعني ليا الشرف النهارده ان اكون انا مورد ليكتشر بروفيسور الهناوي. طبعا بروفيسور الهناوي هو mentor in classification. It's my honor that we worked together before in the last 30 years of our department. The first thing to say is, as Charles Kelvin, the inventor of Phaco classification, said, doctors relate, patients decide. And when Professor Hussain asked me to give a lecture about Phaco cataract in general, I started to think about what I want to say. I have a lot of videos, I have a lot of different audience on different levels, beginners, experience, others. So I dusted off all my videos and started to collect what's beneficial for us. So the aim of this lecture is four parts, four compartments. It's a message to the beginners, and the tricks to the average surgeon, and a tip to the advanced surgeon, and the truth about the technology. How can I help? The step one manual in Phaco classification. I have a patient who has cataract. The beginner start thinking.
ممكن نطفي الإنو.
The average surgeon say
نطفوها امبارح.
What about the experienced surgeon? A lot of things will come in mind for the experienced surgeon. Is it worth it? Is it safe to do it? The patient's trust is high. What's the best for this patient? Is it a simple case, challenging case, is cornea, nodules, hardness of the nucleus? The personality of the patient, which is the most important point. How to communicate. We heard from Dr. Ismail Hamza in the morning, as long as the patient is plenty happy, don't try to re-finalize or do anything as long as the patient is happy. So the personality of your patient is very important. How to deal with the communication, how to connect to the patient, how to reach his mind on all levels and different IQs. Glasses for near and for far, neither. You have to discuss with the patient the technology of the surgery, the type of the intraocular lens, the benefit. You have to tell him that either you're going to benefit in the near and need glasses for the distance, or glasses for distance and get rid of near. If you are a writer or a professor who needs the near works, you can put him -2, anything. Which are going to put? Monofocal, toric, multifocal. Which technology? Extra care, Phaco, Femto, and what's next? So, for the beginners, to start with, you have to have straightforward case, and there is no straightforward case. You have always to consider every case as your first case. You have a clear cornea, the keys of success, normal depth of anterior chamber, good red reflex, grade 2 to 3 nucleus, and stable lens. Good capsulorhexis, good hydrodissection, hydrodelineation, and Phaco classification as you are used to do. The message in this video for the beginners: when you start your rexes, please do the rexes the way you want, but try. When you get the rexes behind an air bubble, please get out the air bubble. But this air bubble will definitely change your refraction, and as the rexes will escape away, this air bubble stays inside. So remove the bubble, then continue your rexes. Let's see the tips for the beginners. 10 tips, not basics, trying to reach the beginners. The first one, the axis. Do the axis the way you want. If you feel the axis is going out, like in this case, I felt here that the axis may escape out. Stop, the third ventral flap, inject this cohesive, flatten the lens again, and then with the capsular axis forceps, hold it and pull it 180 degrees against, in the way, against the direction. To have the whole summation تبقى محصلة القوة تغير الدايركشن بتاع الكبسولة الاكس بتاعتك بدل ما كانت هتسحب لبره اسحبها تاني 180 درجة لجوه هتلاقي الدايركشن بتاع الاكسس جه معاك وتكمل الاكسس عادي جدا بعد كده. As we all know, for mature cataracts, we have to stain to see the axis. I know many of the experienced surgeons not staining depending on the tenting of the capsule, but staining definitely for the beginners facilitates the axis. When you have the axis crumple, as the second tip I'm going to say, the spatula in the other hand helps in flattening the axis in order to see what you're doing then complete your axis. The second tip is the visco dissection, which is a little bit debatable. All of us are doing the regular hydro dissection, hydrodelineation, and these facilitate the rotation of the seed. If the visco dissection is an help and not a must to separate the nucleus and the epinucleus from the capsule. But in a case like this, when the hydrodissection fails, in spite of having soft nucleus, and you cannot do the good hydrodelineation, or it is difficult to rotate the nucleus, if the visco dissection is very helpful. As you see here, the rotation is difficult. Injection viscoelastics under the capsule, exactly like the hydrodissection, definitely it facilitates rotation of the nucleus. So viscoelastization is very helpful. The third tip is the air bubble in the anterior chamber. As you see here, in spite of the severe turbulence in the anterior chamber, there is a small air bubble that's always behind the cornea in the end of surgery. This means that the cornea is protected with visco. Keeping this small air bubble in the anterior chamber all of the time till the end of surgery means all this turbulence, ultrasonic power is away from the endothelium of the cornea, and this is the key of having clear cornea after the surgery. The fourth tip is the nuclear division. Usually divide the nucleus, as you see in this animation, outside the eye horizontally. No, make it obliquely, not horizontally like this, in one direction and the Phaco tip in the other up direction. Obliquely and not horizontally. This oblique division of the nucleus helps division easier and complete division, as you're going to see now in the video. After having the trench, trying to divide it horizontally, and when I change the direction, making the spatula at the level lower than the level of the Phaco tip, it facilitates division of the nucleus. So the oblique and not only the horizontal division of the nucleus gives more ample space for the nucleus to see, to divide, and to have a good red nucleus. This is a very important point. When you have a trench dividing the nucleus, trying to get the nucleus, you are trying to include it. When you remove, supine your hand, and this will appear here more from outside. This supination of your hand helps occlusion. How can I convince you with this? Let's see this. When you are trying to get this watermelon, putting the fork to try to occlude, you will never ever get it except by supination of your hand. So this supination helps in occlusion. Let's see again the video. Trench, division, and then putting the Phaco tip inside the nucleus body, supine your hand to get it out. This facilitates a lot in getting the half of the nucleus out instead of direct occlusion. Nuclear fragmentation. Have a small piece that runs away from the Phaco tip. Try to put the second hand spatula behind to compress it between the Phaco tip and the spatula. This again facilitates getting the nucleus in the Phaco tip instead of getting away. Seventh, visco before taking out the Phaco. All of us, after finishing the Phaco, getting out the Phaco probe, and this definitely decompress the eye. Please, before getting the Phaco